Good afternoon, everybody. It's nice to see a reasonable crowd. I had thought just 2 or 3 people that I'll be speaking to. And it's really funny. I am seeing a picture of Erysipelas after 20 years. So it just goes to show how you get into super specialized practice and you actually forget the very basics of MBBS that you may have studied for more than 5.5 years. So although as I understand, not many surgeons over here, but it would still make sense for you all to pay at least 50% attention, because see, principles, whether it is surgical field or medical field, are the same. How we approach a health related issue are always same. So maybe in your whatever practice that you might go back to, you might find some hints from even the surgical colleagues. Okay, so the first part will be, I'll club the two together, try to make it as quick as possible. But I expect you all to take away some messages, because there'll be a short question answers, which ma'am had insisted should be part of the presentation. So what is a surgical site infection? One would tend to think, of course, any place which has surgery, any infection over there will be a surgical site infection. But just to establish uniformity, when you look at data coming from multiple countries, there's this some kind of a timeline which has been given. So infection related to a surgical procedure that occurs near the surgical site within 30 days following surgery, or up to 90 days following surgery where an implant is involved. Now, this is not the only definition for surgical site infection. As many surgeons are there, or as many organizations are there, those many definitions are there. But this is accepted. Most publications use this definition. So I am highlighting this particular definition. There's another acronym, which is asepsis. It actually summarizes how you will diagnose a surgical site infection. Like, for example, any surgical incision which has need for an additional treatment. A, presence of serious discharge. S, erythema, purine exudate. There's separation of the tissues. If you send a culture of the discharge from there, you get an isolate. And anything which prolongs a post-operative stay would also be called a surgical site infection. So why is it important? Because as I think all of you all realize that it is a very common nosocomial infection. In fact, in surgical patients, 30% of the patients, more than that, depending upon the type of surgery they undergo, can have a round of surgical site infection. And it is not that just because you become better surgeons, you've got better antibiotics, you've got better hospitals, better care, the incidence is decreasing. Actually, because you've become better surgeons, you've got better hospitals, you've got better antibiotics, we are taking on more in the form of more aging population, patients with more comorbidities, and the standard of care is not the same across the world. I mean, I won't call us as low-income countries, but let's say for healthcare purposes, if we call India as a middle-income country, we try to compete in our surgical results with the West or the high-income countries. But the instruments, the facilities, the environment available to us is really not of that class because of economic considerations, not because of anything else. So we still need to know surgical site infection as we knew it maybe 40, 50 years ago. Again, what does it do? It increases morbidity, of course, can be associated with mortality, probably will also increase the hospital stay, increases cost. And in the malignancy setting, it delays start of adjuvant treatment. And if your luck is on the wrong side, you might land up having to face a litigation or even other punitive measures. In the West, they're very serious about surgical site infections. So are we. It is just that this federal punitive measures probably are not applied so strongly to us as yet. So, for the purposes of wound description, we have wounds are classified into 4 categories: clean wound, contaminated wound, contaminated wound, and a dirty wound. What is a clean wound? Clean wound is when you're incising a skin and there is no inflammation encountered between your incision to wherever it is that you want to reach. Like if I'm a gastrosurgeon, if I'm in the abdomen, whichever abdominal organ that I want to reach. But suppose if I were a neurosurgeon, I would have to incise the skin of the scalp, and from there, the subcutaneous tissue, the periosteum, the bone, and then reach the brain or wherever it is in the brain that I wanted to reach. Similarly with the urologist, the gynecologist, whoever. Okay. So the potential cavities, respiratory, alimentary, genital, or urinary tract are not entered. These wounds are primarily closed. Primarily closed means because there's no infection, we close them on table itself. You may add a drain if you want for whatever reasons, but these are clean wounds. So anything which involves entry from the skin, which is surgically created, can be called a clean wound. Now we've added another category 1D to this, in which you enter through the skin, but your procedure also involves insertion of a prosthetic device. It could be a mesh or valve. Now, this has implications because if you're not inserting any device inside the body, just call it a clean wound and get done with it. But if you're inserting any kind of processes inside, either a mesh because of hernia repair or any intracardiac device, then probably the considerations become slightly different. So clean contaminated, you do open the GIT or respiratory tract or the genitourinary tract, but it is under controlled conditions. So there's not gross spillage of urine, there's not gross spillage of fecal matter, because somehow you've been able to control it and there's no major break-in technique. These wounds also are primarily closed with or without a drain. But because you've opened up these potential cavities which contain commensals, which contain organisms, and of course the colon and rectum contain uncountable number of bacteria, there is a break-in technique. So this is called a clean contaminated wound. Contaminated wounds are fresh accident wounds because they would be contaminated with the soil or whatever material they found in the area where the injury has occurred. Secondly, wounds or surgeries where there's major breaks in technique. So there is spillage from either the GI tract or an infected urinary tract. And dirty wounds, of course, a fresh wound, even if it is dirty, even if it is contaminated with soil, washing the wound mechanically takes away a large quantity of the bacteria. But an old traumatic wound is classified, given special emphasis, and is classified as a dirty infected wound. Because old wounds generally will have devitalized tissue. They would have inanimate objects which have been there for a long time. So they become a stronger source of sepsis. So that's why it's been given a separate category. And of course, abdominal, intra-abdominal perforations, definitely they are dirty infected wounds. So what happens? All over the world, generally accepted rates, clean wound, although there is no intrinsic bacterial floral contamination, still surgical site infections can occur, but should be to the tune less than 2%. In a clean contaminated, should be less than 8%. In a contaminated, 15%. And in a dirty, up to 40% wounds, even with the best of cares, will have surgical site infections. So which are the organisms? Generally, they are endogenous from the skin or the mucosa or the hollow viscous, obviously. But what one also needs to remember that the surgical team, the air, the environment, the implants, the gloves, sometimes the medications also, how you administer them, they might also all have a role in development of surgical site infections, and one has to be aware and actively prevent this from happening. More than 50% are gram positive, obviously Staph aureus, because that is the commonest commensal on the skin surface. But especially in our specialty, 30% may be because of gram negative organisms as well. And in 5%, we might also have to keep in mind that it could be an anaerobic bacterium giving rise to the infection. And another observation which is coming around is from infected surgical wounds when you culture. You don't culture all wounds, but when you do culture and you do the sensitivity analysis, you do find that 60% have antibiotic resistance patterns. So best not to get into it that far. So this is just to again drive home the same point. Clean procedures, mostly Staphylococcus. If it is a clean procedure in the groin or perineal area, you might also have to keep in mind that you might have to deal with gram negative and enteric organisms. For clean contaminated wounds, that is either you are entering the respiratory tract or the GI tract or the genitourinary tract. Remember which tract you are encountering and keep in mind those might be the bacteria. In dirty infected wounds, it will be the bacteria which are already present in the wound. So, you'll have to be guided by that. And another thing which is the thing, people who are immunocompromised, like transplant recipients, they can have all kinds of unique patterns, so don't be surprised. Now, so why is it that all wounds don't end up with surgical site infections? Because although there are commensals, although you break the integrity of the mucosal surfaces, although you open up the viscera, with several other adjunctive measures, you're able to decrease the amount of contamination of the wound. But there are some factors which increase the risk of surgical site infection. So what are they? Good patient related, and of course, hospital related. So advanced age, poor nutrition status. I don't think I need to even go through this. These are like for all of us now, this can be fitted into any question which asks for risk factors. Obesity, long preoperative stay. But things to note, coexisting infections at remote body sites. You might want to do a laparotomy, but the patient is having otitis media, may not be the best time to do a laparotomy. Then altered immune response, as I said, patient who are undergoing transplantations. And another thing is multiple blood transfusions. I just feel very strongly about this because the general tendency is now blood is so clean as in the chances of transmitting infections through blood transfusions is so low. So it's like if blood is there, just give it. Yeah, why give it back to the blood bank? No, blood transfusions have effect at several levels of a surgical care. Now, the personnel and the environment related, as in to the healthcare providers, how you scrub, skin antisepsis, whether preoperative shaving is done or not done, duration of operation, use of antimicrobial prophylaxis, how the air circulates in the operating room, sterilization of the instruments, use of or leaving of foreign material in surgical sites, use of surgical drains, and poor surgical technique. All of this also have a bearing on the development of surgical site infections. But remember, it is still our body, it's amazing. It's very forgiving to the surgeons. Because even if you're obese, it doesn't mean that you will get a surgical site infection so long as all the other parameters are looked into and taken care of. That is why it is so important to know what you can take care and what are inevitable. You're not going to refuse a patient surgery just because he's a high diabetic. You're able to control the diabetes, and you have to make sure that the other risk factors are, their play is kept to as minimum as possible so that you have an acceptable rate of surgical site infection. So if we have to look at strategies, obviously if you keep the risk factors in mind, it's very easy to understand this. It's complex because there are multiple factors which come into play. Only thing is, don't think of it as, chalta hai, this is okay, this is a small price to pay. Somehow when we work, we think, okay, if you have done a big surgery, the wound infection is a small price to pay. It is not. Because you agreed to do that particular surgery, and that he will have to pay with it, with a wound infection which will take a long time to heal. He'll go with a gaping wound to his home. That was never told to him, and that was not what the patient agreed to either. So don't think of this as a small thing, which is a minion thing which can just be ignored. It's just like a price to pay. It's not, and certainly not in the West. So what can we do? Few things, very easily doable if you keep it in mind. Avoid emergency surgeries unless it's really life-threatening. All over the world now, emergencies are only for, emergencies meaning operating during the night hours where everything is compromised. It's only for active bleeding which cannot be controlled by any other method. Otherwise, suggestion is convert it into an elective procedure, whatever you might need to do it, to achieve that. Another advantage besides taking care of your manpower problems and sterility problems is that it gives you time to optimize the patient's physiology and nutrition. Look for and treat distant sepsis, especially if you're going to insert a prosthesis. Take care of the patient's nutrition. It might seem, of course, but when we talk about at scientific forums, we have to look at what is the evidence available also. So it's not that giving a patient rich carbohydrate diet or just giving the patient rich protein diet is going to enhance his nutrition. The only two factors which have been found is glutamine and arginine. But still, it's common sense that a well-fed patient, as in not an obese, but a well-fed patient, I'm sure you understand what that means, is a much better surgical candidate than a malnourished patient. So take care of the nutrition if you can. Use minimally invasive approach where it is possible. At least in abdominal surgeries, laparoscopy procedures are associated with lower rates of wound infection than open procedures. And another thing, stop smoking. It has a huge impact. One would think it is important only from the respiratory point of view, it's important only for the anesthetist. No, even as a surgeon, for you also, it's important that the patient gives us smoking. And the recommendation is for at least 4 to 6 weeks. Yeah. So, how do you prepare the patient who is supposed to undergo a surgery? It might seem very simple. Every day you have a bath. What's the big deal? But when patients come to the hospital, I can challenge each one of you to go and ask a patient when was the last time he had a bath. It won't be funny that the last time he had a bath was when he left his house. So if he has been admitted in your ward for the past 7 days, he has not had a bath for the past 7 days. And the reasons could be as simple as, in this weather, there is no hot water available in the bathroom. Okay, so don't assume anything. You have to tell the patient that he has to have a bath before going for surgery. And it doesn't require to be some high-end antimicrobial soap. Simple, whatever soap that he likes or is available is good enough. Okay. One important myth that all of us carry, but which has been totally disproved by literature, so we can't discount it however much we might be uncomfortable with it, is shaving of the parts before undergoing surgery. Now, I am a gastrosurgeon, so am I comfortable operating on an abdomen which is non-shaved? For a female patient, doesn't really matter, but in a male patient, not really. Okay, because the ends of hair, they stick down, they enter into the wounds when you incise. Doesn't look good, doesn't feel good. So then what's wrong with shaving? Problem is when you use a razor to shave the patient or to prepare the part that you want to prepare before incising, it causes multiple lacerations on the wound, on the skin surface. And this is where the organisms find entry into this thing and increase the chances of wound infection. So it's not that shaving is contraindicated. Sorry, hair removal is contraindicated. It is not that at all. If you're comfortable operating on a hairy part, so long as it is clean, of course, go ahead and do it. And if you're not comfortable, it doesn't mean that you still have to do it. It means that you have to use alternatives to shaving, which is a depilatory cream. Am I making myself clear, please? Even in neurosurgical procedure, I mean, how can you operate on a head which is full of hair? Okay, so you have to remove the hair, but don't use a razor. You can cut it short, and then for the remaining stumps, you can use a depilatory cream. And obviously, depilatory cream will take more time, so either you don't shave the entire head, you just shave that part of the area that you want to operate. Okay. Then, since Staph aureus is found everywhere, why not use Staph aureus decolonization? Routinely, it is not suggested, only for surgeries which will have a negative outcome if Staph aureus infections were to develop at the surgical site. So generally, only patients undergoing cardiothoracic surgery with implantations, orthopedic surgeries, again where implants are used, or in a patient who is already immunocompromised. There is suggestion that 2% mupirocin nasal ointment for 5 days and chlorhexidine wash for 5 days may help to decrease Staph aureus as a component of the wound infection. In the OT, please take care of small things, but this has a very important bearing in your surgical site infection outcomes. It makes sense also to have someone in the OR whose sole responsibility is to ensure that people follow these guidelines. So having an infection control program and a nodal person whose responsibility is to make sure that all the facets are actually implemented is a very good idea. For hand hygiene, like how do you wash your hand before undertaking any surgery or any invasive procedure? Between a soap solution and alcohol-based hand rubs, it's now proven that alcohol-based hand rubs probably are better. Not that soaps cannot be used, even a soapy solution can be used. It's just that alcohol-based hand rubs, your contact time you may get away with a smaller contact time than with the soapy solution. The soapy solution, you have to make sure that you're washing your hands for at least 2 minutes. With the handheld, with the alcohol rub, you might get away with a smaller duration. Use appropriate surgical attire and barriers, limit traffic through the operating room, and use this laminar airflow system. The laminar airflow system is this thing where each layer of air is not allowed to cross ventilate the entire extent or the entire volume of the OR. It is given in layers. Okay. Now, it might seem very nice that, this is how the OR should be constructed, but the practical problem to this is that this is a very expensive undertaking to have, okay, and probably not really required. The idea is just to understand that if you have it, fine, but even if you don't have it, even air barrier systems have been found to be equally effective. Just don't allow contaminated or grossly polluted air to enter inside your OR. Drapes, it doesn't really matter whether you wear disposable gowns or you wear the cloth gowns. Just make sure that they're clean and sterile. One thing which is to be avoided is when you're draping the patient, avoid plastic drapes and sticky drapes. Now, patient is on the table. How do you prepare the part which you're going to incise? The idea here is only to reduce the burden of skin flora, at least at the site where you're going to operate. Remember, you're not going to be able to eradicate it completely because this flora will be residing in the hair follicles or sebaceous gland, but at least decrease the volume of that particular flora. What will happen is then whatever does enter you inside through the skin, through the incision will be dealt with by the body's natural defense mechanism. So chlorhexidine based solutions are believed to be superior than povidone iodine based solutions. So nowadays, betadine, like when we were doing our residency, betadine scrubs were the rage in the OR. Everybody used to get a betadine full massage. But now chlorhexidine based solutions have been proven to be superior because it has been shown that chlorhexidine is not inactivated by blood or serum. And this is particularly relevant in our field. Now, what about wound protected devices? So these things have been developed in the market. Everybody tries to sell many things. So what is done is you have this kind of a contraption, this kind of a thing which you insert in the wound, so that what happens is the wound edges don't get contaminated by whatever is in the bowel. It is good if it is there, you can use it. And another thing which they do is they prevent the wound edges from drying out, because drying out a wound also increases the chances of wound infection. Yeah, this is while you're operating. Now, this is a request for the anesthesia colleagues. You all also have a very important role to play in preventing surgical site infections. It is not just making the patient sleep and making him wake up at the end of the surgery. Maintain normothermia, because hypothermia triggers vasoconstriction and this decreases subcutaneous oxygen supply. And this is again the reason why smoking is this thing. If possible, use high oxygen during GA and for some time after extubation. Minimize blood transfusions, ensure good intraoperative sugar control, and use patient warming devices to ensure normothermia. Now again, one would think, these are small things, what is the big deal? It is the small things which matter, like it or not. And it might seem cliches, everyone says this, but that's exactly, unfortunately, how life and how things are. People have actually done studies on this, and they found that just using these 5-6 strategies actually decreased their hospital infection rates as opposed to the national average. The other option or other strategy which is commonly used is irrigation of the surgical wound. Once you finish the surgery, you have closed the fascia, you take a wound, take a liter of water and wash it like a utensil. Well, intuitively it might seem right, whatever bacterium is, I'm going to throw that thing out of the field. But the point is, whatever you do, you have to understand that your movement, your hand, your rubbing should not push the microbes into the crevices of the wound. So if you want to irrigate, you have to use the jet of the irrigant to wash whatever is there in the wound away, and not use your hand or not use a gauze piece and rub the wound. Okay. Yes, causes trauma, pushes the bacteria inside. Yes. Now, again, as I said, all of us are very fond, use technology, use this, use that. So lots of pharma companies oblige very happily. Lots of stuff available in the market, all kinds of dressing, and as expensive as you can possibly want to use. But actually just a simple sterile dressing like this is good enough. If your closure has been correct, if you have taken care of the risk factors, if your intraoperative steps have been correct, this will heal as effectively as use of any of these other stuff. Now this is just to tell you this because we use this strategy in our ward. So if at all you'll come to see a consultant in our ward, you might have a patient, you might see a patient with this and wonder what it is. So this is called negative pressure wound therapy. Now again, it is believed that applying negative pressure to a wound edge helps to get the wound edges closer, increases the blood supply over there and helps in tissue healing. We don't use it in all the wounds because one, it is very expensive. Secondly, it is disabling to the patient. Only when you have reason to believe that there's a lot of when you have reason to believe that there's a lot of skin damage, or you think that there's some patient has got underlying decreased blood flow, or there's bleeding or a lot of dead space, then you might opt to use negative pressure wound therapy. Especially for GI surgeons, there are only two. So I'll just finish this up in one slide. This is a huge discussion by itself. Bowel preparation before colorectal surgery. See, one thing you have to understand is there's no way you can sterilize the colon. Okay, the only idea of using any kind of bowel preparation, what we do is we use mechanical catharsis to decrease the amount of solid fecal matter within the bowel wall. So mechanically, you're trying to decrease the volume of the content to a smaller amount, and you combine it with oral antibiotic. But even if you use bowel preparation, at least for the gastrosurgeons, it does not replace the need for intravenous antimicrobial prophylaxis. So then, what is antimicrobial prophylaxis? That is a full lecture by itself, so that will be another 5 slides later. I'll get into it. Now, when to suspect a superficial surgical site infection? If you see any erythema, induration, tenderness, any discharge, any fluctuation, any crepitus around the wound, this is not a good idea. But in a surgical patient, finding a crepitus should not necessarily raise a red flag. Of course, you can call us, but in any patient post-laparotomy, you can have some amount of crepitus around the wound edges, which may not be very ominous at all. And some of the surgical site infections can have systemic manifestations with fever, leukocytosis, and systemic signs of sepsis. So this is a standard diagram that we have in which we divide the access route to intra-abdominal organs into superficial, where you have the skin, then you have the subcutaneous tissue, then you have the deep soft tissue, which includes the fascia and muscle. And of course, you have your organs wherever it is that you want to do this thing. So any infection in the skin and subcutaneous tissue is labeled as superficial incisional SSI. Infection which involves the fascia and the muscles is labeled as deep incisional SSI. And infection deeper to that is called organ or space SSI. So when you suspect, what do? First thing, open the incision to establish adequate drainage. Don't wait to say that let it localize, I'll open it up tomorrow. Or it will unnecessarily make the wound open, patient will be unhappy. Patient will be even more unhappy when he has a bad wound at the end of 7 days. So the first suspicion of infection, open the wound. Separate the edges gently. Look at the fascia. If there's any necrotic tissue, debride it. Look for crepitus and decide about the use of antibiotics. All patients with surgical site infections do not require antibiotics. But if there are systemic signs of infection, I think ma'am has also said in some way the same things. Essentially, as I said, principles are all the same. So if the systemic signs of infection, if the erythema extends more than 5 centimeters from the incision head, there are elements of tissue necrosis, you might have to combine it with IV antibiotics. And of course, the choice would depend upon your likely pathogen. Now, if you open the wound, what do you do next? So generally, when you open the wound because of a surgical site infection, there are 2 strategies which you can use. One is you just do daily dressing and allow the wound to fill up from within. Problem with this is called healing by secondary intention. Problem with this is that it will take a long time to heal, but it will heal and the infection will not progress further. So previously, this used to be the strategy most common. Any wound which is infected, open it up and then leave it to heal by delayed by secondary intention. But then some people thought that why increase the morbidity of a wound to the patient? I mean, for us as medical people, it is no big deal to see an open wound. But for a patient and his attendants, it is very grotesque to see an open wound like that. So now we also use this delayed secondary closure. That is when we think that the tissue edges are healthy, the tissues underneath the wound edges are healthy, we go for something known as delayed secondary closure. Now, I'm mentioning these two terms, laparoscopy and vacuum-assisted closure, again, because any of you all come to surgical gastro wards for consultation, you will see some of our patients, not all of them, with a laparoscopy and vacuum-assisted closure. So what exactly, so again, so this is just a picture. This is a patient following lap cholecystectomy, no dressings required at all. This is had a laparotomy. Again, you can leave the wound perfectly open. There's absolutely no problem with it. Just make sure that these ends of the knots that you have this thing, they should not interfere with his clothes. They should not get stuck in his clothes. That's the only thing to take care of. Open wound, perfectly fine. Because epidermal sealing takes place within 24 hours. So actually, you don't need a dressing for 24 hours. And if you're going to put a bad dressing or an infected dressing, it is best not to have a dressing. At least his clothes would have been washed daily. Now, this is an example. This is an example of a superficial wound infection. See, you can still see the erythema of the skin edges. This is when this wound was opened, and these deep tissues are healthy. And this was a small seroma in the inguinal region following inguinal hernia repair. Now, this is a deep SSI. Okay, if you can see the entire, this is an incision on the anterior abdominal wall for a splenectomy. This you can see, this is a skin and subcutaneous tissue, and this is some amount of devitalized tissue on the fascia as well, but essentially it is clean. This is an example of a burst abdomen. You can see the bowel protruding, which can be easily seen between the wound edges. So this is what I mean when I say this kind of a wound we may allow to heal by secondary intention, and it does heal. Okay, so it is not something which is, it does happen. It's just that it takes a longer time, but it does happen. This is vacuum assisted closure, wherein, because you don't want to see a wound like this, so what you do is, so this is a custom made dressings, of course. So you take this polyurethane foam, cut it to the size of an incision, you pack that incision, and you connect a tubing to it, which is connected to give you negative pressure. So this negative pressure sucks in all the effluent which comes from this wound edges, keeps the wound dry, and also is supposed to increase the blood supply and improve wound healing. Now, dramatically and again conceptually, again looks very, very fine and very promising, but even this works very well for us. Okay, this is our custom made, what we do in the ward most of the times, because this is an expensive business. We just take a simple clean gauze piece, okay, connect tubing to it. This is connected to the wall mounted suction, which is there on all the beds, and we just seal it off with this back to bend or a sterile tape. Works. I'm not sure if it works equally well or not, but it definitely works. Point is, more expensive things are not necessarily better. Okay, so long as you understand the reasons why thing is happening and you're aware of the principles of treating it. So the thing about antimicrobial prophylaxis. Now, why do we use microbials in surgery? Because despite whatever you might do, you still have clean wounds infected to the rate of 3%, clean contaminated to about 7%, contaminated to about 15 to 20%, and dirty up to 40%. So despite whatever mechanical care that you might take, is there anything else that can be done? So people really questioned that, is antibiotic prophylaxis in surgery a really effective option? So in this particular meta-analysis, where they included about 23 studies, 23 different surgical procedures, and they found that the relative risk of infection, okay, if you can see over here, between whether you used antimicrobial prophylaxis, the number of patients who used antimicrobial prophylaxis divided by the number of patients in whom it was not used, the relative risk in all the surgeries was less than 1, which goes to prove that antimicrobial prophylaxis is actually effective in reducing the risk of wound infection for all types of surgeries. So what is it? It is just a very brief course of an antimicrobial agent, which has to be started before the surgery begins to prevent SSI, essentially by reducing the burden of microorganisms at the surgical site during the operative procedure. Remember, it is not an attempt to sterilize tissue. It is not that all the microbes are taken care of. It is not an attempt to sterilize tissue. It is just an appropriately timed. Now, these things are very important. It has to be a critically timed adjunct to reduce the microbial burden of intraoperative contamination to a level that cannot overwhelm the natural host defenses. So, here again, you have to understand this distinction. The idea of antimicrobial prophylaxis, although it is used in all surgery, it will not prevent, or it is not used to prevent surgical site infection in a wound which is already contaminated. Okay, because a wound which is already contaminated, it will develop infection. So those wounds are treated differently. Antimicrobial prophylaxis does not apply to those wounds. They will already be having treating antibiotics. Okay, and after a wound is created, after a surgery is completed, even if all things are all right, and somehow you contaminate the wound because of bad procedures, your use of antimicrobial, peri-operative antimicrobial prophylaxis is not going to prevent that. So, where is it proven to be literature-wise very effective? When the risk of infection is relatively high, for instance, in clean contaminated or contaminated operations, because in these two categories are the only categories where appropriate attention to every detail, including antimicrobial prophylaxis, actually decreases the incidence of wound infections. Dirty wounds will anyway get infected. Clean wounds should ideally not get infected. But clean, contaminated, and contaminated groups are the categories in which appropriately timed antibiotics before the incision or during the surgery can help to decrease the incidence of surgical site infections. And of course, they are imperative when the development of a surgical site infection would have disastrous consequences. For example, if you're using prosthetic vascular grafts, orthopedic implants, etc. So again, the microbiology, we've already been through this, so I won't repeat this again. This essentially guides your choice of antimicrobes. The fungi, whether we like to believe it or not, they are being isolated, more and more from surgical site infections. So one has to be aware of this. And another interesting thing, people have actually done these studies and found that even in the Western hospitals, anal, vaginal, and nasopharyngeal carriages of group A streptococci were operating room personnel. They have caused outbreaks of surgical site infection. So how you as a healthcare provider dress up, glove yourself, mask yourself, carry yourself in the OR has a role to play in surgical site infections. Not just the surgeon, including the person who cleans the OR, including the sisters, including the technicians, including the anesthesia technicians. So how does one choose? Well, obviously, it will depend upon the antimicrobial activity that one wants to counter. At the same time, one would consider cost, safety, and pharmacokinetic profile of the particular drug that we choose. And this, I think we have to remember now that broad spectrum antimicrobial agents result in lower rates of post-operative SSI compared to narrow spectrum antimicrobial agents. So keeping that in mind, generally the choice is first and second generation cephalosporin, and second generation cephalosporins with anti-anaerobic cover like cefoxitin or cefotitan, with addition of separate anti-anaerobic cover like clindamycin or metronidazole might be preferred in clean contaminated wounds. So generally, as I said, cephalosporins are the choice of drugs. Cefazolin is the most commonly used. I'm talking about abdominal procedures now. It's active against streptococci, methicillin susceptible staph, and gram-negative organisms. Most importantly, it has an excellent safety profile and low cost. Now, one thing to remember that when guidelines are made, when societies give recommendations for the choice of antibiotics, they have to give across a wide range. But that doesn't mean that you as a clinician cannot apply a clinical mind in the particular patient. But if you're doing 500 laparoscopic cholecystectomies, which actually are clean procedures, okay, you will want to use antibiotic because if it prevents infection in 1 out of 500, maybe it is worth it for that particular patient. But at the same time, those 500 should not be made to pay 1,000 rupees for the antibiotic just to prevent that one infection. Somewhere you have to strike the balance. So cefotaxime is used when you want to use a broader coverage against gram-negative organisms, but of course resistance is increasing, so this is not generally the first choice. Cefoxitin and cefotitan, they have anaerobic coverage as well, so they might be preferred. Just a point which I came across, so I thought I would share it, that cross reactions actually between penicillin and cephalosporins are actually infrequent. I mean, generally the thing is, if a person says that I've had penicillin allergy, the common standing instruction is don't use cephalosporins because he's got penicillin allergy. It is not that way. It is not all penicillin allergies will be allergic to cephalosporins as well, unless it is a severe IgE mediated reaction. And for cephalosporin allergies, of course, we have this gentamicin, ciprofloxacin, levofloxacin, and all that. Now, vancomycin, routine use, it is not to be indicated. You might want to use it when one has identified a cluster of SSIs. okay, due to MRSA or MRSA cons, or a patient is known to be colonized with MRSA. Known to be colonized meaning your nasal swabs, your groin swabs have grown with MRSA, and you're planning a device insertion. Then in those patients, you might want to use vancomycin for antimicrobial prophylaxis. And a patient is at a high risk for MRSA colonization, and for some reason you cannot obtain nasal swabs, or you can't wait for the results of those nasal swabs, or patients who have had recent hospitalization, immunocompromised, long antibiotic stay before coming here. For those patients, you might want to use vancomycin as a choice for antimicrobial prophylaxis. Now, when do you give it? 60 minutes prior to the surgical incision. The idea being you want to have adequate drug levels circulating at the time that you actually make the incision. If you're choosing a vancomycin or fluoroquinolone, you use it 2 hours before the surgical incision, because you want to use an infusion from the anesthesia point of view, because if by chance vancomycin causes a reaction, you don't want that to happen too close to your anesthesia induction time. Now, so antimicrobial prophylaxis is 1 dose of the antibiotic. How about redosing? So, since the idea is just maintenance of adequate tissue and serum concentration for the course of the operation, redosing is only if you are using antibiotic with a short half-life and your surgical procedure is turning out to be very long, or there has been a rapid and excessive blood loss during surgery, and probably if it is a morbidly obese patient. Now, duration, this is again a practice which is not followed, but the recommendations are no role for antibiotics within 24 hours, and only in cardiovascular patients and probably some transplant patients who are immunocompromised to start with, you might consider your choice of antimicrobial prophylaxis for 48 hours. Again, as I said, there's evidence to it. So if you want, these are not things which I'm saying off the cuff. There's evidence to it that there is no point continuing antibiotics. And this, although there is evidence to it, we still continue to do it. You will still in surgical wards find antibiotics, prophylactic antibiotics continuing for 5 days. So actually these were the society recommendations, guidelines for different surgical procedures, but I guess we can skip all this. This is in any specialty, you will have your own set of organisms, you will have your own set of diseases, and these are available everywhere. So I will skip this set of slides. Now, hospital strategies. There are international guidelines available. Please use them, follow them, maintain local data regarding incidents, trends. If you find suddenly there's a spurt of surgical site infections in the wards, please make a note of it, try to find the reasons for it. And it's a good idea if every hospital or every surgical department has an antibiotic stewardship program. So try to keep your patient in the ward for as short as possible before the surgery. These are just very simple, basic things from all these previous slides, which I thought it's not too difficult to remember. Have a bath. It is very trivial, but I'm again saying it because I've seen this happen again and again. Do not shave. Use antibiotic as an antimicrobial prophylaxis strategy. Give your attention to the drug that you use, the timing, the dosage, appropriate skin preparation, maintain glycemic control, normothermia, oxygenation, and use appropriately timed antimicrobial prophylaxis. No substitute for meticulous surgical technique. Post-operative vigilance equally important, and have an antibiotic stewardship program. Thank you. So there are some questions, but I kept them very, very simple because at least this much you should be able to answer. So just say yes or no, amas, that is also fine. So would you think that shaving of private parts complements general hygiene of a surgical patient? Yeah, it is just for you like to see it that way. It does not compromise or it does not augment the general hygiene of the patient, medically speaking. Okay, so shaving is not necessary. Hair removal, if it suits you or if it suits a surgical procedure, is a different matter, but shaving to achieve that is not recommended. Clean cases do not need antimicrobial prophylaxis. Okay, fine. So even if there's a yes or no, it's fine, because actually it is controversial whether clean cases need antimicrobial prophylaxis or not. Technically, they should not need, but they don't need if all your other strategies are correct. As your skin preparation is correct, your instruments are correct, every other thing is correct. But if you're not working in a perfect environment, maybe you can use single dose antimicrobial prophylaxis for clean cases as well, which is what we do. What about this? Good idea to give a shot of antibiotic at the time of skin closure to prevent surgical site infection? No, there is no evidence. Although you might think it might be a good idea, you know, बंद करने से पहले एक बार दे ही देते हैं, क्या होगा, अच्छा ही रहेगा, अच्छा नहीं रहता है, ठीक है? It is not to be done. Broad spectrum antibiotics are better at preventing surgical site infections. No, I think I had mentioned it is. You use a much because you don't know what organism you're dealing with. You have a general idea, okay, but you limit it once you get your sensitivity reports. Antibiotic stewardship programs are only for medical disciplines. I wanted to write over here. No, they're equally important for surgical disciplines as well. Okay, thank you very much.